Health for Life. This is the first ever medical show on television that deals with prevalent health problems and concerns, and they do so in an easy to listen to question and answer format. To find out what we're discussing today and to introduce us to the visiting specialists, here is the producer and the host of Health for Life, Dr. Surendra Prasad.
So again, zooming in on the hip and the knees, which are the two more common ones that the patients are concerned with. What would be some of the laboratory studies you might be getting?
In degenerative joint disease, your laboratory studies are usually normal.
Okay.
So we would do laboratory studies if we are suspecting that the degeneration might be associated with other conditions other than just the natural degeneration or aging of a joint. And those cases would be, if you're looking for sepsis, then you do laboratory studies, a CBC, ESR, CRP. You're looking to determine if there's any associated infections. Of course, if there is malignant conversion or something happening in the joint that's causing the degeneration, then of course your alkaline phosphatase and other little studies can help you. Thyroid disorders can also cause degeneration, bony disturbances, so you can study the thyroid. A patient who has renal failure, for example, because of the way the hormones work, you can also have degenerative changes happening. So the laboratory studies that we do are dependent on any comorbid conditions that the patient may have associated with their joint pains that we would like to study. But the actual straight osteoarthrosis, you don't really get anything positive in your laboratory studies. Complementary X-ray studies or imaging now, X-ray, the simple normal X-ray will give you your diagnosis.
Okay.
And the things that you will notice in the X-ray would be the formation of spurs on the sides of the bone, decrease in the joint space, and sometimes you see irregularities on the joint surfaces.
Okay.
And deformities may be seen if the condition is very severe. You can either go into valgus, meaning moving away from the body deformities, or varus deformities. So you find that a patient with a knee osteoarthritis may come to you and say, "Doc, apart from all the other things I'm getting, I'm noticing that my knees are bowing." So they're actually pointing you to this knee that is changing its architecture, and it tells you that's arthritis.
Now you said that plain X-rays can give you the overwhelming majority of information. Is there any role for any of the advanced imaging studies?
The role for other advanced imaging studies is dependent on the grade or the state in which the joint is, and if the doctor is suspecting that you may have an associated, take for example the knee, you have an associated meniscal degeneration. Because there are some patients who have osteoarthritic changes in the knee, but what's causing most of their problem is that the meniscal degeneration is becoming entrapped in the knee.
Okay.
So an MRI would help you. But on a regular basis, there's no need for an MRI in a patient that you have an X-ray that diagnoses osteoarthritis of the knee.
Okay. How is degenerative joint disease treated?
To treat the patient with osteoarthritic degeneration of the joint, it depends on the stage in which you find the patient, when the patient consults. If the patient consults early, then it's a lot of preventative, dietary, and exercise that's going to help this patient. So diet meaning we are trying to prevent the patient from getting heavier, so we advise them on adequate diet or the best way to eat to keep their weight down so that they don't put the amount of pressures on the joint that would make it degenerate faster. Exercise is vital. You need to exercise, and we always say, especially for the knee, the stronger your muscles are around the knee, the better is your knee. So even if you have a degenerate knee and you have good muscles around it, that knee works way better than the guy who has a degenerate knee with poor muscle to assist that knee. So exercise is important, but we have to make certain that our patients are not doing high impact activity.
Okay.
Because remember, you have a degenerate knee, and then you're going to be running on the seawall. So you're banging that knee on the seawall. So it's probably not the best thing. The treadmill is also high impact. Many people don't realize it. And the treadmill, and if you put it on an incline, is even worse. So we kind of try to move our patients away from high impact activity. We know that aerobics is a highly recommended thing in a patient with osteoarthritis. But you need to also select which form of aerobics you're doing. The jump up ones, doing the steps and things like that, you probably might be better off not doing them. You can do your stretches and all the other low impact activity in aerobics, and that's great. And of course, bicycle riding or pedaling and swimming are about the best exercises for a degenerate hip and knee.
So let's say that again. So you want the persons to exercise, but you don't want them to do any exercises where their feet are hitting a solid surface, such as running on the seawall or the treadmill. But bicycling or swimming would be the ones you would prefer. So there's no major impact.
Yes.
Now,
once you reduce, sorry. Yeah.
Go ahead.
Once you reduce the impact on the joints, they're going to get their muscles strong, they're going to be able to exercise, they're going to keep the range, but they will not assist with the degeneration by trauma.
Now, when they're using the bicycle, are there specific recommendations or instructions you give them as to where the seat should be and what degree of flexion they should have on the knee?
Yes, and that's very, very vital, because if the patient is using the cycle and their saddle is too low, they usually come back and complain that they can't use the cycle because it's hurting them. And that's because if the saddle is too low, you're flexing the knee past 90 degrees or about 90 degrees, and that knee cannot take that amount of flexion, so it hurts. So very important when you're going to use the cycle is that your knee should not flex so much. If you're using an upright cycle, it's simple. You just stand at the side of the cycle, you flex your thigh, and wherever your thigh at 90 degrees is, that's the height for your saddle. And that's simple. If you're using a recumbent cycle, then usually you push the seat as far back as possible so the bend of your knee is much less. And that's what you do.
Now, you talked about obesity, and today obesity is an epidemic problem, and we always talk about obesity and the hypertension, the diabetes, and the metabolic syndromes. But now we are beginning to see the role, or I guess the detrimental role, that obesity is playing in joint diseases. Comment about obesity and degenerative joint disease.
It's very important for us to remember that when we walk, we are taking our body weight on the lower limb. When we are going through the transition phase of walking, where we're switching from one foot to the next, the knee, the hip, the ankle actually takes 3 to 5 times our body weight. So when my patients come to the clinic and I'm speaking to them about obesity, I don't usually tell them about obesity. I tell them about the weight that they're putting on the knee as they walk. And then I show them that if I am 10 pounds extra, I am putting 50 pounds extra on my knee. If I am 50 pounds extra, then I multiply that 50 by 5 and I am actually putting 250 pounds extra on my knee. And then the next question I ask them, can you lift 250 pounds? If you can't, then you should not make your knee try to lift it. So that's the importance of making the patient understand how obesity will influence negatively on their joints. And that's why we need to try to keep our weight down if we want to save our joints.
Now, what about surgery? At what point or when is the indication, when your patient has degenerative joint disease, that you begin having the conversation about the surgical options?
Now, the surgical options in degenerative joint disorder are multiple. And it depends on the stage in which we catch the patient, we get the patient. There was one time that arthroscopic shaving of a knee or a hip was touted as a good thing to do. And it's still practiced sometimes. But it just depends on the cause of the pain. And like I said, you can have an arthritic knee. It's not really arthroscopic shaving of the joint. It's arthroscopic correction of the meniscal degeneration that may be entrapped in the joint that makes the difference. It's not how much I shave the cartilage that is worn that's going to make a big difference. The patients tend to get relief for a short time. So arthroscopy can be used, but it's not really a solution to the problem except the patient has meniscal degeneration that is being entrapped in the joint that is arthritic. Then you have osteotomies. And what do I mean by osteotomies? That's when the knee, for example, or the hip, there's a zone of that joint that is degenerate, but another zone is not so bad, or completely void of degeneration. So we can actually do geometrical changes to the architecture of the joint. So I move where they're taking their weight to another section of the joint. Those are known as osteotomies, and we usually do it in the knee. It's known as a HTO, or a high tibial osteotomy. And we can do this kind of surgical intervention to give the patient a little more longevity of their joint, especially the knee. But it's not going to resolve the problem. It's just going to give them probably a year or two, sometimes 3 years more. But then the degeneration is there and it will progress slowly. So osteotomies have been recommended in cases that patients have unicompartmental osteoarthritis of especially the knee, and you can do that kind of surgery. It's not so practiced in Guyana because most of the patients, when they consult with you, they have both compartments already compromised, and if you do an osteotomy, you're not really going to resolve their problem. The other form of surgery that is done are joint replacements. And joint replacements, the indication is when you have so much of progression of your disease that both compartments or the entire hip is affected, and this condition is affecting your quality of life. And that's when we decide the best thing to do is a total joint replacement. But there are uni-compartmental replacements for the knee that are also available. We don't do that in Guyana. But if one compartment is affected and the other compartment is okay, instead of having a total knee, you can have a uni or a unilateral knee replacement. That's having some problems in the world because most patients with unis end up having to return for a total knee replacement. So it's a little controversial if unis should be done, but they're still being done, but there's not everyone will benefit from a uni.
Now,